You know that feeling when just everyday stuff suddenly becomes, well, a real struggle?
Yeah.
Like trying to wrestle open a jam jar, or maybe even just that little twinge you get in your thumb scrolling through your phone. I think we've all been there, or know someone who has. Today, we're really zeroing in on that kind of thumb and wrist pain. We're doing a deep dive into DeQuervain's Tenosynovitis. And you, our listener, actually shared your notes on this, which is fantastic. So our goal here is to crystallize that info, get the key details down so you can understand it, and, importantly, recall it easily.
Exactly. Think of this as your focused revision session on DeQuervain's. We'll break down what it actually is, look at the causes, who's more at risk, how it physically affects the body.
What else it might be mistaken for.
Right. The differential diagnoses, and also who it typically affects, how it presents itself, how we diagnose it.
To treatment, too.
Definitely treatment options, what to expect long term, and yeah, what might happen if it's, left alone. So let's jump in.
Okay, first up, the definition. Let's get really clear. What exactly is DeQuervain's Tenosynovitis in simple terms?
Okay, so basically it's an inflammation. It specifically affects two tendons, the abductor pollicis longus, or APL, and the extensor pollicis brevis, the EPB. And it's not just the tendons, but also their coverings, their sheaths right there at the base of the thumb.
Ah, the sheaths, too.
Yeah, and that inflammation is what causes those classic symptoms, the pain, the swelling, and that real difficulty moving your thumb and wrist properly. And interestingly, you see it most often in women, typically between 30 and 50.
Okay, so that's what it is. Pretty clear. Now, why does it happen? What actually causes it? What's the etiology here?
Well, pinning down one single cause, that can often be a bit tricky, but there's a really strong link to repetitive strain.
Repetitive strain, okay.
Yeah, involving the thumb and wrist. So think about activities with lots of repetitive gripping or maybe twisting motions, lifting things again and again. These sorts of actions, especially if you do them a lot, can irritate those tendon sheaths over time, and that eventually leads to the inflammation. Sometimes, though, it might even be triggered by, like, a one-off injury, some kind of trauma.
Repetitive strain.
Yeah.
That makes sense. You could picture it. Are there specific things, maybe jobs or hobbies, that put people at higher risk?
Oh, definitely. Certain jobs are known culprits. Things requiring those repetitive thumb and wrist movements, maybe assembly line work or carpentry, they carry a higher risk. But it's not just work. Even hobbies like, say, gardening or spending hours gaming, they can be factors too.
Gaming, right.
And as we mentioned, it is more common in women. And there's a really notable increase during pregnancy and in the period after birth, the postpartum period.
Yes, pregnancy and postpartum, you mentioned that demographic link. Is there a specific reason why it seems more common then?
The current thinking, really, is that it's probably a mix of things. Hormonal changes that happen during pregnancy and after.
Right.
And also just changes in body mechanics, how you hold yourself, how you lift the baby, perhaps. These shifts might just make those tendons and their sheaths a bit more vulnerable to getting inflamed and irritated.
Interesting combination. Okay, so we've got inflammation of tendons and sheaths. Let's dig a bit deeper. What's happening on a sort of biological level, the pathophysiology?
So the process involves that inflammation we talked about, right?
Right.
Affecting the APL and EPB tendons and that synovial sheath. Now, the sheath is like this slippery lining.
Helps things glide.
Exactly. Helps the tendons glide smoothly inside their little tunnel at the wrist. But with repetitive motion, or those tiny repeated injuries, microtrauma, we call it this sheath, can actually start to thicken up. So imagine that tunnel getting narrower because the lining inside is swelling, puffing up.
Okay.
This narrowing means there's more friction on the tendons every single time you move your thumb. And it's this increased friction that leads to the pain, maybe some visible swelling, and that limited sort of uncomfortable movement.
It's like the tunnel gets congested. Okay. Now, if someone comes in with these symptoms, thumb pain, wrist pain, what else could be going on? What other conditions might look similar, the differentials?
Yeah, that's crucial for getting the diagnosis right. A few things can mimic DeQuervain's. Osteoarthritis, particularly at the base of the thumb, that first carpometacarpal joint, that's one, though you tend to see that more in older people.
Okay, what else?
You could have radial nerve entrapment. That can cause pain in the thumb and wrist area too, but often you'll hear about burning or tingling, sort of pins and needles, paresthesia. Then there's something called interception syndrome. That's also tendons rubbing, but the pain is usually felt a bit higher up the forearm, more toward the back of the wrist, more dorsal and proximal.
Higher up. Okay.
A ganglion cyst near the wrist might cause some discomfort, but often it's more of a visible lump and frequently not actually painful, usually dorsal too. And lastly, maybe gouty arthritis. that can hit the thumb base with sudden, really intense pain, redness, swelling. But the onset is usually very acute, very inflammatory looking.
That's a really helpful rundown of the possibilities. Now, we touched on the demographics, UK women, 30-50. What else do we know about who typically gets DeQuervains? The epidemiology.
Yeah, that specific group, women aged 30-50, that's a key takeaway. And like we said, the higher rates during pregnancy and postpartum are also really worth remembering. But while we know these groups are more susceptible, getting precise figures on just how common it is across the entire UK population, well, the stats aren't particularly well documented, actually.
Right, not always easy to track. So let's imagine someone coming into the clinic. What are the classic things they describe? The clinical features that make you think, this could be DeQuervains.
Well, the absolute telltale signs are pain, tenderness when you touch the area, and often some noticeable swelling right there at the base of the thumb on the wrist side. Sometimes they might say the pain shoots up into the forearm a bit.
Radiating pain.
Exactly. And they'll almost always report that the pain gets a lot worse when they do things involving gripping, grasping objects, or pinching. They'll also likely find moving their thumb and wrist, especially trying to move the thumb away from the palm and extend it, is just difficult and painful.
And if you examine them, what would you typically find?
On examination, you'd expect to find that pain specifically on the radial side of the wrist, the thumb side. There's usually tenderness if you press right over the radial styloid process, that bony lump on the thumb side of your wrist. You might also trigger their pain by asking them to, say, abduct their thumb, move it away from their hand against a bit of resistance. But the real diagnostic clue, the classic physical test, is Finkelstein's test.
Ah, yes, Finkelstein's. Everyone learns that one. Can you just walk us through how you do it and what a positive result really means?
Sure. So for Finkelstein's, you ask the patient to make a fist, but tuck their thumb inside their fingers.
Thumb tucked in. Got it.
Then, as the examiner, you gently but firmly bend their wrist downwards towards the little finger side. That movement is called ulnar deviation. While you're doing that, you might also apply a little bit of gentle downward pull, like a longitudinal traction down the forearm. Now, if doing that causes a sharp, distinct pain right along that thumb side of the wrist where the tendons are, that's a positive Finkelstein's test.
And that strongly suggests DeQuervains.
It's a very strong indicator, yes. You're essentially stretching those inflamed tendons within their tight, irritated sheath, and that provokes the pain.
Makes sense. So with those clinical signs, maybe a positive Finkelstein's or other tests usually needed, what about investigations?
Often, no. In, I'd say, the majority of cases, the diagnosis is clinical. It's based on the story, the symptoms the patient describes, and what you find on examination, especially that Finkelstein's test. But sometimes imaging, like an X-ray or an ultrasound, might get used.
And why would you use imaging? When is it helpful?
Well, it can be useful mainly to rule out other things, those differentials we talked about, especially if the picture isn't totally clear-cut, or maybe to get a sense of how severe the inflammation is. X-rays, though, are typically normal in DeQuervains. They don't usually show anything specific.
Okay, so X-rays usually clear. What about ultrasound?
Ultrasound can sometimes show more specific things. You might see thickening of those APL and EPB tendons, or sometimes, interestingly, you might see some thinning of the EPB tendon, possibly because the overlying band, the retinaculum, has thickened and is pressing on it. You might also see signs of increased blood flow on Doppler ultrasound hypervascularity, which indicates active inflammation. But again, the key thing to remember is that imaging isn't always required. The clinical assessment, that's usually primary.
Right, clinical diagnosis is key. Okay, so we've diagnosed it. What's the approach now? How do we manage DeQuervains? What are the treatment options?
So management usually kicks off with conservative measures. These are the non-prescribing things first. The main focus initially is rest for that thumb and wrist, and modifying activities, basically stopping or changing whatever seems to be making it worse.
Activity modification, crucial.
Absolutely. And immobilizing the thumb and wrist with a special splint called a thumb spica splint is really important too. That doesn't mean wearing it 24/7 necessarily, but definitely during activities that stir it up, and often at night as well. Applying ice packs regularly can also help calm down the inflammation.
Okay, rest, modifying things, splint, ice.
What about medications? The pharmacological side.
Yeah, for pain relief and tackling the inflammation, NSAIDs, non-steroidal anti-inflammatory drugs are often the first line. Things like ibuprofen or naproxen. If the symptoms are persisting despite those basic measures, then a corticosteroid injection might be considered.
An injection directly into the area.
Exactly, right into the tendon sheath.
Yeah.
Often it's a mix of a steroid, maybe methylprednisolone, combined with a local anesthetic to numb the area briefly. And what if even the injection doesn't quite do the trick, or the relief doesn't last? Is surgery an option?
Surgery is usually kept for cases where conservative treatment and injections haven't worked well enough. It's actually relatively uncommon to need it. The procedure itself is called a dorsal compartment release. Essentially, the surgeon makes a small cut to release that tight band covering the tendons, relieving the pressure.
Creates more space for the tendons.
Precisely. And in those persistent cases, surgery generally works very well.
That's good to know there's an effective option if needed. Now, thinking about revision, remembering those initial steps is key. Can we come up with a simple mnemonic for the conservative management?
Yeah, good idea. How about rice tea? It's a bit of a stretch from the standard rice, but it works here. So R for rest, I for ice, C for compression. Think of the splint providing that support, and gentle compression.
Right, the splint as compression.
E for elevation. Well, less direct for the wrist, maybe, but it implies reducing overall use, keeping it supported. And T for therapy, meaning that crucial activity modification. So rice tea. A pretty straightforward way to remember those initial non-drug treatments.
Rice tea. I like it. Okay, so what's the typical journey for someone with the DeQuervains? How likely are they to get better? What's the prognosis?
Generally, the outlook is pretty favorable, provided they get the right treatment and, crucially, make those activity modifications. Most people see significant improvement in their symptoms, usually within, say, a few weeks to a couple of months. But, and this is important, it can come back, especially if you jump right back into those repetitive activities without thinking about technique or maybe workplace ergonomics.
So recurrence is possible.
It is. So ongoing self-care and awareness are pretty important to stop it flaring up again.
Okay. And lastly, what happens if it's just ignored or maybe not managed properly? Are there potential complications?
Yeah, if DeQuervain's isn't treated or it's managed poorly, the main risks are developing chronic persistent pain and also significant functional limitations, finding it hard to use your hand and thumb for everyday tasks, which can obviously really impact quality of life. In really rare, severe, long-standing cases, there's even a small risk of the tendons actually rupturing.
Wow, tendon rupture. That's serious.
It's very rare, but possible, which just underlines why getting it diagnosed early and managed properly is so important to prevent these kinds of issues down the line.
Absolutely. Highlights the need to seek help. Okay, to really lock in those key diagnostic points, let's try a quick, maybe MSRA-style question scenario.
Good plan. Okay, imagine this. A 42-year-old woman comes to you. She's complaining of pain right at the base of her thumb. She says it's much worse when she tries to grip things, like opening jars. On your examination, you find distinct tenderness when you press over her radial styloid process. And crucially, when you perform a Finkelstein's test, she reports sharp pain along the thumb side of her wrist. What is the most likely diagnosis?
And based on everything we've just discussed.
The answer would be DeQuervain's Tenosynovitis. It just brings together those key features: the location of pain, the aggravating factors, the tenderness over the styloid, and that positive Finkelstein's.
Perfect. Really hammers home those clinical clues. Okay, so just to quickly recap the absolute essentials from this deep dive on DeQuervain's, we're talking inflammation of those two specific thumb tendons, APL and EPB, and their sheaths, usually linked to repetitive movements. Diagnosis is often clinical, with Finkelstein's test being a really key indicator, and treatment starts with conservative stuff: rest, splinting, ice, activity changes, aiming to reduce pain and inflammation, possibly moving on to injections if needed.
That sums it up nicely. And it really does make you stop and think about all those small, repetitive movements we make every single day without even noticing. Hopefully this discussion encourages you, the listener, to maybe consider the ergonomics of your own daily activities and how these seemingly minor movements can add up and potentially impact musculoskeletal health.
It's a great point. Definitely some food for thought for all of us. And if you found this focus revision useful, remember to check out PastTheMSPray.com and also FreeMSPray.com for loads more resources. Thank you so much for joining us today as we took this deep dive into DeQuervain's Tenosynovitis.